So full disclosure as well, that's correct. I am affiliated with UBC. I'm also a senior scientist at the BC Centre for Disease Control. And Max, he also recently finished his master's degree in the School of Population and Public Health at UBC. And this is some of the data that he was using towards that project. So we really appreciate you having us here. It's been a while since I've presented to BC Transplant, so it's nice to be back. Next slide. So we can do another land acknowledgement. So we just want to acknowledge the land on which we work, live, and play is the unceded territory of the Coast Salish peoples, including the territories of the Musqueam, Squamish, and Tsleil-Waututh nations. And additionally, we really wanted to acknowledge the persons and families and friends of persons who have died from illicit drug toxicity, who have made the selfless gift of organ donation. Their donations have saved the lives of hundreds of British Columbians, and we really wanted to make sure that they were acknowledged before this talk. As a funding disclosure, so this work was made possible through the Transplant Research Foundation BC Venture Grant, and we did this work in collaborations with Dr. Keenan, Drs. Toma and Dr. Levy, as well as the Yvonne and Pravin and Heidi and BCC staff. So this is really a group effort, and we want to thank everyone for contributing. So I think it's fair to say that everyone on this call knows that transplantation is the preferred treatment option for individuals with end-stage organ failure. It's life-saving, and then in addition for end-stage kidney failure, it improves quality of life and is cost-saving as well. And our waiting list is growing every year as our population is aging. And in Canada, we have about 5 to 7% of individuals on the transplant waiting list who die every year. And if you include those who are withdrawn from waiting list due to deteriorating health, then that number increases quite a bit. And so basically this figure here is from the Canadian Institute for Health Information. It just shows over time for Canada how sort of early in the 2010s we were increasing the number of deceased donors that we have, and since in the last 5 years it's been relatively plateaued. So that's at a Canadian level. But we know that the need for transplantation continues to exceed the availability of organs that we have. So I found this picture online yesterday, and I really like the faces on the Herrick brothers. It looks like they're posing for the camera here with sort of like a, wow, we're going to be part of something really cool. And in fact, it was really cool. So this is prior to Ronald Herrick donating his kidney to his identical twin brother, Richard, in 1954. This was the first transplant. So it was a living donor transplant between identical twins, as I mentioned, and Richard was able to live for 8 years after that, which is really quite unbelievable at the time. And Ronald lived until the age of 80 and died about 10 years ago. But I mean, this is such an amazing contribution to his brother and to science, and we are grateful for that. So just thinking about from the first transplant, how has the organ donor pool expanded? So this list is not complete, but to kind of just give you an overview or a reminder of the history. So started with living donation, we moved on to deceased donation. And originally it was really that these organs had to be perfect matches, right? So identical twins, then you go to related donors, unrelated, and then we moved into having non-directed donors. So unrelated donors who were really altruistic in the sense that they did not have an intended recipient that they wanted to donate to, but wanted to donate to the general population that was at need. Then we expanded that even to have these dominoes and kidney paired exchanges as an example. And so we've really sort of, there's been a lot of innovation in what we've been able to do in the field of organ donation. And then in addition to that, among deceased donors, we've expanded our criteria. So it used to be more so that we would accept young and healthier donors, but we now have older age donors, donors with more comorbidities. We have treatments for hepatitis C, so we can do more hepatitis C positive donation after cardiocirculatory death, which has been around for about 15 years now. And so all of these really exciting ways that we've been able to innovate and move the field forward. And then additionally, We've been able to improve things with use of allocation. So we've been trying to improve equity, for example, through things like the highly sensitized registries. But in addition to that, we do have matching based on donor and recipient longevity. So for example, we match kidneys in BC, like young to young and older to older. And the reason that we did that was to basically minimize the waste of kidneys, of sort of young kidneys that we were being donated to people that would not be able to use them for the life expectancy of that kidney, and making sure that we were able to make the most efficient use of the organs that we had, while at the same time maintaining justice in that we did not want people to be prioritized for transplantation such that every young person would get an organ first. So we've maintained that equity, but improved efficiency for kidney donation. And there are similar examples in other countries and other things for other organs. Next. Oh, and then I guess I would just say one thing that I saw last night was that I guess there's a recent paper out that they've been doing some work on organ donors, and now it seems like they may be able to eventually change the blood type for a donor. So this is still early stages, but the idea here is that we're continually advancing the field, and as the need continues and we're moving towards self-sufficiency, there are lots of people coming up with good ideas. So I think one misnomer that is probably relatively clear in this population of listeners, but I think in the general public is not very well understood, is that wanting to be an organ donor upon death is not sufficient criteria to end up being able to donate your organs. There are obviously multiple steps after death that need to be sort of ticked off to make sure that you qualify to be a donor. One of the big ones is really you need to be able to be in hospital when you die or sort of in that process of death. And then you need to be mechanically ventilated. Also, there are multiple exclusions for organ donations, such as age, and then different types of cancers or multiple organ failure. And then we have to go through the whole process of consent, etc. And then after that potential organ donor has been accepted and secured, then to help them become realized into actual donors, there's still the procurement process, and then, you know, whether the organs are going to actually be able to be used. So it's a long pathway, and I think maybe it's more obvious to some of us who work in the field, but I really think that as we educate the public and our partners, it's really helpful to put all of this in context to give them a sense of where we're at. So we did some work a few years back on identifying individuals who could be potential organ donors, and our restriction criteria were basically that they had died in hospital, and we had that they were under the age of 70 years, but still very small proportion of these individuals are able to donate. And that does differ by age. So obviously, the older you are with more comorbidities, those numbers drop. And then finally, I just want to be really clear. So organ donation, as we all know, is a right. It should be something that is an end-of-life decision that should be respected for every individual. And what really drove me to start working on this project, so when I first moved to the BC CDC in 2017, was sort of right in the middle of the overdose crisis, and or just as it was taking off, and I'd just come out of working in transplant and organ donation, and this seemed like I just wanted to make sure that as we were having more deaths as a result of drugs toxicity, that we would find a way to destigmatize these deaths and to make sure that all of those individuals had the same rights at the end of their life as everyone else. Next slide, please. So I mentioned overdose, but really our language around this now is we're calling it in BC the unregulated drug poisoning emergency. So previously you would hear overdose, dose, or opioid epidemic, but this is the language that we are now using going forward. If you hear this, it's the same thing. So these two figures are from the BC Coroners Service, and they're updated routinely. So if you look at the slide, the figure on the left, you can see in the y-axis we have the number of deaths, and in the x-axis we have this by year, so from 1996 to 2022. The blue bars represent the counts, and the blue line represents the death rate per 100,000 people, which is on the second y-axis. So you can see that until about 2014, the rate of illicit drug toxicity death per 100,000 population was fairly stable, and then it started to increase 2015, 2016. There was a substantial increase, and that's when the provincial emergency was declared. And you can see that this increase continued. There have been multiple interventions that have been put in place, and some of that likely accounts for the stabilization and the drop in 2019. But then we had COVID and everything else, and our numbers are continuing to increase. 2022 data is not complete yet, but the rate is still, the current rate as to where we are today is very similar, above 40 per 100,000 population, which, to put in context, is about 5 or 6 deaths in the province per day. So this is a lot. And in fact, I don't have the slide with me today, but this is sort of in the recent years is the first time in decades that the life expectancy of the population is actually decreasing, and this is driven by this population. And just to let you know, so definitions of illicit drugs are on the coroner's website as well, but this includes things, illegal drugs such as fentanyl, methamphetamine, MDMA, but also includes prescription medications that are taken by individuals who they're not prescribed to or not in the way prescribed. Okay, and then on the right-hand side, again, this is from the coroner's report. It's the counts of deaths on the y-axis and year on the x-axis. And these flat lines from the top are relating to suicide, motor vehicle deaths, homicide, and prescription drug deaths. So although there are some changes in these over time, they are very small in comparison to that solid dark line, which is the other unnatural cause of death in BC, which is our illicit drug toxicity deaths. So just to put that in context, where this isn't something that everything is increasing over time, this is really a stark difference from what's happening with everything else. Next slide, please. Okay, so who is dying of illicit drug toxicity in 2022? So basically, drug toxicity deaths can happen to everyone. They're occurring in all parts of the province, in all age groups, and among both sexes. 86% of those that are called drug toxicity deaths from the coroner include fentanyl. A small proportion include carfentanil, but there's also heroin, MDMA, methamphetamines, and sometimes these are also include analog benzodiazepines. So it's not that there are often multiple drugs involved in each of these deaths, but fentanyl is really what has been the huge change in the patterns that we have seen in the last 5 years. 7 in 10 deaths are among individuals 30 to 60 years of age. So these are very young individuals who are dying. 3 in 4 of these deaths are among males. So although males are more impacted, we still have about 25% of those who are dying of illicit drug toxicity are women. And then I mentioned this last point, just thinking about sort of who could become a potential donor, be eligible for donation after death. So the majority of these occur inside a home or another residence, but some of these do occur in a locked bathroom where someone has overdosed. And then 16% occur outside on the street, in the car, in the park. So often these individuals who overdose are practicing alone, and so may not be able to be rescued with naloxone or other therapies. And so this is just to highlight that this is a problem that is affecting everyone. Next slide, please. Okay, so this is sort of what led us to think about this study. So we know that the number of individuals who are dying from drug toxicity deaths has increased substantially. And we know that in the US, for example, there have been studies that have shown that increased risk donors, including individuals who die after illicit drug death, are often underutilized or overly discarded. Or that patients may refuse these organs. And so given the fact that we knew that we had more of these deaths, we knew that some of these individuals were becoming organ donors, we really wanted to show with the data and information that we had that the practices that we had were safe, or if not safe, but really just take all of that information, because BC has the highest numbers of drug toxicity deaths in Canada, and this was even true back in 2016. So I'll hand it over to Max here. Thank you.
Thank you, Caren, for that background. So the way we then conducted this study was we explored two main research objectives. The first was to look at trends and characteristics of drug toxicity death donation. The second was to compare survival after transplantation from a drug toxicity death donor to a transplantation from a non-drug toxicity death donor. And this was compared also by organ type. For our data source, we used the BC Transplant Patient Records and Outcome Management Information System, the PROMIS database, and we had to do chart review of donor drug toxicity status. This was done by BC Transplant's Medical Director of Organ Donation Services. So thank you, Dr. Sean Keenan, for doing that. We then restricted data to donors that are 12 to 70 years of age between January 2013 to December 2019. This age and time period reflects those who are dying of drug toxicity who were donating to the organ donor pool and the time period in which this was increasing. Lastly, we only looked at local deceased donors, again, we were able to identify that had a drug toxicity death status. For some exploratory analysis, we looked at donors donated per statistics over time by drug toxicity status. And we also compared characteristics of donors by drug toxicity status using the chi-square test, Fisher's exact test, or Wilcoxon rank sum test as appropriate. When we were only looking at drug toxicity death donors, we see that in the time period, we had 148 of these donors. They donated and resulted in 469 transplantations. Then this figure further breaks down what kind of organ transplants these were, but mainly they were kidney, liver, heart, and bilateral lung, with the other smaller sample size transplant groups being single lung, pancreas islet, and certain combination transplants. For the outcome that we wanted to look at, we chose recipient death and recipient all-cause graft loss. For recipient death, it was simply death censored at retransplantation or end of follow-up, which was August 23rd, 2020. This outcome was analyzed for bilateral lung, heart, and liver recipients. We then looked at all-cause graft loss, which was the experience of graft loss due to any cause, including death, censored at end of follow-up. And this was only done for kidney transplant recipients. And this was done because, as many of you may know, kidney transplant recipients have the option to go back onto dialysis if their graft fails. So for the kidney analysis group, we wanted an outcome measure that captures both graft loss as well as death. The statistical methods for the outcome analyses were used to look at time to death or time to all-cause graft loss. And first, we used the Kaplan-Meier method to estimate 1, 3, and 5-year post-transplant survival probabilities. Then, for the risk of death or all-cause graft loss, we used first an unadjusted Cox proportional hazards model at 3 years post-transplant, as well as an adjusted, and this is adjusted using weights, as well as multiple variables, so multivariable Cox proportional hazards model at 3 years post-transplant. The weights for the weighted multivariable Cox model were derived using the inverse probability of treatment weighting method. This is a propensity score method. And essentially what we're doing here is we're trying to balance recipient, donor, and transplant characteristics in these observational groups that we are comparing. So we can single out what is the association of donor drug toxicity status on these transplant recipient outcomes. What we found was that over time in the study period, the volume of deceased donation increased. Proportionally, however, non-drug toxicity death donors did not greatly change, but the proportion of drug toxicity donors did increase in this time period. Overall, there were 605 deceased donors who donated 1,795 to 1,795 transplant recipients, and this resulted in 1,857 transplants. Approximately 25% of these deceased donors were drug toxicity donors, and approximately 75 were non-drug toxicity deceased donors. For organs donated per donor statistics between 2013 and 2019, we saw that for non-drug toxicity death donors, the median organ donated per donor did not greatly change over time. But for drug toxicity donors, the median number of organs donated per donor increased from 3 to 4. And this increase was largely due to more hearts being utilized from younger drug toxicity donors. When comparing the donor characteristics of all of these donors, we found that donors were more likely to be male. Drug toxicity donors were more likely to be male, more likely to be white, of a young age group, have a higher last measure creatinine, be HCV positive, more likely to be flagged as an increased risk donor, and more likely to donate a heart. Drug toxicity donors were less likely to have a history of hypertension or a history of diabetes. But we have to sort of point out that those characteristics were of the general donor population. Within each organ group, then we had differing frequencies of these donor population characteristic distributions simply due to the selection of donors in these organ groups. So if we look at the first column here, we're essentially looking at double lungs or bilateral lungs, and we're saying there were 223 donors in total in this analytic sample, but the drug toxicity death donors were more likely to be male, younger, white, and less likely to have a history of diabetes, hypertension, more likely to have a higher last measure creatinine, and more likely to be flagged as increased risk. So those characteristics sound very similar to the overall donor population when comparing drug toxicity and non-drug toxicity. But when we look at the second column here for heart, we see that there are less white boxes filled in here because there was less variation in the characteristics of drug toxicity donors and non-drug toxicity donors that donated a heart. So this matrix kind of just shows that for all of the organ groups. But generally, we can also see in the organ groups where there are differences in characteristics between drug toxicity donors and non-drug toxicity death donors. They have a greater sample size but because the heart organ group only had 110 transplantations for analysis, it may partly be contributing to the insignificance we're seeing in these characteristics. We then did a similar matrix like this for the recipient and transplant variables. One item I would like to point out is in the last column here in the kidney group, and when we're crossing it with recipient age, drug toxicity donors who donated to a transplant recipient, those recipients were more likely to be young. So this is likely due to the kidney allocation algorithm that we have in place, which is also partly based on donor and recipient age. But as we can see, for many of the other characteristics, there are no white boxes labeled because there just isn't variation of the recipient characteristics between recipients that received a drug toxicity donor organ versus those that received a non-drug toxicity donor organ. And this is a good thing. And from our transplant physician consults, they have also told us that donor drug toxicity status is not a measure by which they allocate organs. In our Kaplan-Meier estimates for all organ groups, as well as regardless of whether the recipient received a drug toxicity donor organ or not, survival was very high at 5 years, cumulatively above 75%. We have the exact numbers here of survival for heart, bilateral lung, and liver, and we can see that they're very similar. But pointing out the kidney organ group, those who received the kidney from a drug toxicity donor actually had a significantly higher probability of not experiencing all-cause graft loss at 5 years. So 97% compared to 83%. Then in our modeled outcomes, we can see that first, in the first column here, model 1, we have the unadjusted outcomes, and then in the second model, we have our covariate and weight adjusted outcomes. Taking the first row as an example, so bilateral lung, there was a 1.39 hazard ratio with a non-significant confidence interval. Then after covariate and weight adjustment, we have a 1.06 hazard ratio, still with a non-significant confidence interval. So this move of the hazard ratio point estimate from a higher value towards the null of 1 is seen throughout all of the other organ groups as well. So it's a common trend. After adjusting that, it seems like there is no difference in the risk of either death or all-cause graft loss between recipients of drug toxicity donor organs and recipients of non-drug toxicity donor organs. But I do have to point out that for the kidney organ group, initially we saw a 0.23 hazard ratio with a significant confidence interval, and that remained the same in our covariate and weight adjusted model. So this is essentially saying that recipients of kidneys from drug toxicity death donors were significantly less at risk of experiencing all-cause graft loss compared to recipients of non-drug toxicity death donor kidneys. And so we were curious about this last model here for kidney, being that it's so significantly protective. So we did perform stratified analyses. As we know, the kidney donor and recipient allocation rules do play a major part in who gets what kidney, and therefore it is a major confounding factor in determination of the outcomes of all-cause graft loss. So we can see we performed 2 sets of stratified analyses. They're separated by the green and blue color. They're based off of a cut point for donor age as well as a cut point for recipient age based on allocation guidelines. So looking at the first row, for example, for those who received a kidney from donors aged 35 years or younger, experienced a significant protective effect of that drug toxicity donor kidney. And this held true in the weighted and adjusted model. But then when we looked at recipients of donor kidneys that were older than 35 years of age, we saw that the confidence interval became non-significant. Either of these outcomes are good. They're saying that the acceptance of a kidney from a drug toxicity donor results in similar and equally good survival for those recipients. Some study limitations that we had were a lack of smoking status, which is theoretically an important confounder in both bilateral lung and heart analyses. Additionally, our heart analyses had a smaller sample size as well as a fewer number of events. Lastly, not many older or more comorbid drug toxicity donors were represented in our analyses. This just means that even though we had methods to sort of balance these characteristics when comparing the observational groups, we cannot balance what doesn't exist. So that is a limitation there. For the overall summary of what we found, overall deceased donation increased for all deceased donors, but proportionally more so in the drug toxicity donor group. However, we do have to mention that the increase in volume of non-drug toxicity donors is also attributable to an improvement in hospital referrals of potential deceased donors over the study period. Drug toxicity donors were found to donate more organs per donor, specifically more hearts for the younger donors. Drug toxicity death donors were also more likely to be young white males with fewer comorbidities. Overall, the 5-year survival, cumulative survival after drug toxicity donor transplantation was very high, and even comparing to the other group as well as amongst other organ groups, overall survival is high. At 3 years of follow-up, when we conducted our adjusted analysis, we found no evidence that transplantation from drug toxicity death donors resulted in worse outcomes. Some considerations of possible disease transmission, specifically related to HCV, as that was the most prevalent condition in our analytical sample, but also in many other literature out there. We do know already that direct-acting antivirals are being used, but also in small sample studies, they have been shown to successfully reduce HCV viral load for transplant recipients that become HCV positive after transplantation from a serologically positive but not negative donor. So then if we consider the risk of accepting an increased risk donor organ compared to mortality on the wait list, multiple studies have already shown that it's better in most cases to accept an increased risk donor organ, as mortality staying on the wait list is much higher. Back to you, Caren.
Thanks, Max. So just to summarize, I just have 2 more slides left. So, I mean, overall, basically the evidence shows what probably many of our practitioners have expected, that drug toxicity death donation, the way that we practice it right now in BC, provides very good patient outcomes. And the demand for transplantation is unwavering. And so utilizing all eligible organs, as we all know, and that's what we work hard to do every day, is important. And the practice has evolved. So as Max showed, we are there was always some donors where there was drug toxicity death as the cause, but you can see that that has increased a lot over time with what is going on in the population. In particular, we're getting more heart donation. And then I think what Max alluded to, which is key to remember, is that the work that we've done really focuses on sort of the pool of donors with drug toxicity death that we have to date. So we know that as the unregulated drug poisoning crisis continues, we have more and more individuals dying, and many of those are older. And so if we start considering more of these older or more comorbid individuals as drug toxicity donors, we may need to continue to evaluate the safety going forward, but there's no indication at this stage. We did have some of these donors in our study, and their outcomes were also very good. So there's no evidence that we should stop this practice. So overall, I think it's important that we can put this out and share this information that the practice is safe and favorable. Max, can you go to the next slide, please? And so I just wanted to share a couple of thoughts with you. So as part of this experience, we worked with our colleagues I always say it wrong because it's still new to me, but in the unregulated poisoning, working in that emergency. And so they work very closely with individuals with lived experience. And so we worked with one of our colleagues who works in this area, and she connected us with one of the groups she works with a lot for the work that she does. And so we had the opportunity to share this work with the community. And I think both Max and I were a little bit surprised by the response that we got. So I think that because the intention behind what we were doing was really just to understand that these individuals are dying, and we wanted to respect them and give them that opportunity to donate and use this evidence to sort of support that. But I think what maybe we missed was the extreme emotion around death in this community. So in particular, there have been a lot of deaths in this community, a lot of high profile deaths lately. These are not all people that use drugs regularly. Some of these are even young people that are going to a party and using drugs, on one-offs, and just having the unfortunate circumstance of getting something that's laced with fentanyl, for example. And so the individuals that we talked to, it was very emotional and very triggering for them. And I think when we first showed this to them, for some of them, all they could see right away was, oh, you're taking all the other things that the government and the system has done to us, and now you want to take our organs and give them to other people. So it's sort of almost an adding insult to injury for them. And then in addition to that, so to put it in context, they were appreciative of us. They knew that we weren't trying to do anything negative for this population, but at the same time, they had a lot of emotions and thoughts around this, which are extremely valid. And so finally, what some of them did recognize is they were saying, it's one thing to donate an organ, but they were very aware that the likelihood of them donating if they died to somebody who looked like them, like to a friend or someone with similar lived experience, may not be possible because many of those individuals will not be eligible for transplantation. And so they felt that that was really unfair. And so to me, this just sort of wrapped up this whole experience for us and really showed me that there's a lot of education that we need to do for ourselves and also for this community, to include them in the conversation, so that we can see their needs and understand, and also hopefully help them learn what we are trying to do and figure out how to do this in a better way. Obviously, there are cultural sensitivities with so many groups, but I think, and I'm sure that is being, and I even wanted to comment about what was happening at the bedside or from the organ donation specialist, but I don't actually know, but I assured them that people had the right intentions. But anyway, it's just something that we can learn from and hopefully include these groups in future conversations. So thank you very much for the opportunity to present.